The idea that diet is medicine is not new. Hippocrates is attributed with some version of this observation roughly 25 centuries ago, and every subsequent era of medical thinking has acknowledged, in principle, that what people eat profoundly shapes their health outcomes. What has been new in the past several years is the translation of that principle from inspirational rhetoric into reimbursable healthcare policy, and that translation, however incomplete, represents a meaningful structural shift in how developed healthcare systems conceptualize the boundaries of clinical intervention. The economic argument driving this shift is straightforward and hard to refute. Approximately 80% of cardiovascular disease, type 2 diabetes, and a substantial proportion of cancer cases are linked to modifiable lifestyle factors, with diet playing a primary role. These conditions represent the dominant cost drivers in healthcare systems across the developed world. If dietary intervention can prevent or meaningfully delay the onset of diet-related chronic disease, the economic case for funding that intervention as preventive medicine is more compelling than the economic case for funding many pharmaceuticals that manage the conditions diet could have prevented. The evidence base for specific dietary interventions has matured substantially. Produce prescription programs in the United States, which provide subsidized access to fruits and vegetables for food-insecure patients with diabetes or cardiovascular risk, have demonstrated measurable reductions in hemoglobin A1C and hospitalizations. The SNAP medical nutrition therapy model has shown similar outcomes. Medicare's 2022 decision to cover medically tailored meals for high-risk patients following hospital discharge was a policy landmark, establishing a reimbursement precedent that advocates have been working toward for years. The implications of formalizing food as a reimbursable medical intervention extend well beyond the healthcare system itself. If medically tailored meals and produced prescriptions become standard covered benefits, the food industry faces new pressures to engage with clinical nutritional standards. Dietetic practice expands from a consultative specialty into a frontline prescribing discipline. The food environment, what is available, affordable, and accessible in different communities, becomes a healthcare infrastructure question, not merely a consumer preference question. The warnings in this space are primarily about equity and about the limitations of individual-level dietary prescription as a solution to population-level food environment failures. Prescribing an individual patient a box of vegetables does not change the fact that their neighborhood may have no grocery stores, that their work schedule may make meal preparation structurally impossible, or that their income leaves no margin for dietary flexibility. Medically tailored meal programs are valuable and should be expanded. They are also, by themselves, insufficient responses to a food system that is structurally organized around the production of cheap, nutritionally degraded, calorically dense products. The formalization of food as medicine is a genuine policy advance. Its impact will be constrained until it is accompanied by parallel intervention in the food system that produces the need for that medicine in the first place.